Today we're talking about Q fever, a really fascinating and, often missed disease caused by the bacterium Coxiella burnetii. We're going to break down its history, its unique biology, and most importantly, the clinical signs that should put this thing right on your radar.
So, first things first, what's with that Q? Where does that come from? Well, believe it or not, when the illness was first described way back in the 1930s among slaughterhouse workers in Queensland, Australia, nobody had a clue what was causing it. It was a complete mystery. So they called it query fever, as in, we have a query about what this is. And the name just stuck. It's a great little piece of medical history that really hints at the diagnostic challenge this disease can be, even today. Okay, so let's meet the bug itself, the culprit behind the query, Coxiella burnetii. Its unique characteristics are really the key to understanding how Q fever operates.
And here it is. This is our guy. Coxiella burnetii is what we call an obligate intracellular parasite. Now, what does that mean? It means it can't survive and replicate on its own out in the open. It has to get inside a host's cells, specifically our macrophages, and hijack their machinery to multiply. It literally hides inside our own immune cells. That's its whole game plan, and it's exactly why it is so good at causing these sneaky, persistent, chronic infections.
Now, this next concept is absolutely crucial for diagnosis, so lean in for this. It's called antigenic phase variation. Out in the wild, in an infected animal, the bacteria is in what we call phase 1. This is the highly infectious, aggressive form. But after you culture it over and over in a lab, it shifts to a less infectious form, phase 2. This isn't just some lab trivia, this is the whole key to our diagnostic tests. The way our body produces antibodies to these two different phases is precisely how we can tell the difference between an acute and a chronic Q fever infection. Super important. So, how does this clever little intracellular bug make the jump from animals to us? Well, understanding the transmission route is absolutely key to figuring out which of your patients are at risk. This diagram lays it out perfectly. The main way people get this is through inhaling contaminated aerosols or dust. See, the bacteria are shed in absolutely massive quantities in the birth products of infected livestock. We're talking cattle, sheep, and goats. Think placentas, amniotic fluid, even feces. When all that material dries out, the bacteria can get kicked up into the air and literally travel for miles on the wind. It's no wonder that veterinarians, farmers, and slaughterhouse workers are the highest risk groups. And, as you can see on the right, because it's so stable and you only need to inhale a tiny amount to get sick, it's also considered a potential agent of bioterrorism.
Okay, so now for the tough part. As we've been hinting, diagnosing Q fever can be incredibly tricky. Its clinical presentation is a real chameleon. It can mimic a whole bunch of other, way more common illnesses.
In its acute form, Q fever usually just looks like a nonspecific febrile illness. Your patient comes in complaining of high fever, crushing fatigue, a really bad headache, often right behind the eyes, and just, terrible muscle aches. They might have a dry cough, maybe some stomach upset. Sound familiar? Yeah, it could easily be the flu or, frankly, a dozen other viral syndromes. But here's the thing, the infection doesn't always stop there. As you can see here, Coxiella can go systemic. It can cause atypical pneumonia, granulomatosis hepatitis, even get into the central nervous system. The most feared outcome, though, is when that acute infection smolders and turns into a chronic one. And that brings us to the big one, the most common and life-threatening form of chronic Q fever, culture-negative endocarditis. This is a huge risk for patients who already have valvular heart disease or immunocompromised. So here's a major clinical pearl for you. Any patient you have with culture-negative endocarditis must be tested for Q fever. It's a diagnosis you just can't afford to miss. So you're suspicious. You've got a patient with a suggestive history, maybe a sheep farmer with a fever of unknown origin. You're thinking Q fever. How do you actually confirm it and start managing the patient? Let's start with a classic and kind of fun finding from pathology. If you do a liver or bone marrow biopsy, you might see this, the donut granuloma. Seriously, it looks like a donut. It's a central bubble of fat surrounded by a ring of fibrin. Now, when you're dealing with all those vague, flu-like symptoms, a finding like this is a powerful anchor for your diagnosis. It's not 100% specific, but it is highly suggestive of Q fever. And it's an incredibly memorable sign that can cut right through all that diagnostic fog. While you can use special stains on microscopy, the gold standard, the real workhorse for diagnosis, is serology. Using a technique called indirect immunofluorescence, we can measure antibody levels, both IgM and IgG, to those phase 1 and phase 2 antigens we talked about earlier. A high antibody response to phase 2 antigens suggests an acute infection. But a high IgG titer to the phase 1 antigen, that is the hallmark of chronic Q fever endocarditis.
So how do we treat this thing? For acute Q fever, the treatment of choice is doxycycline. Simple enough. But starting it early is really key to preventing the disease from progressing to the chronic form. Now, chronic Q fever, especially endocarditis, is a much, much tougher fight. That requires a long-term course of combination therapy, usually doxycycline plus hydroxychloroquine.
And that brings us to our final thought here. Q fever is the great pretender. It can look like the flu, like viral hepatitis, like community-acquired pneumonia. So the next time you have a patient with a stubborn fever of unknown origin, especially if they have any exposure to livestock, just ask yourself, could this be the query fever? You have to wonder, how many cases are we all missing simply because we aren't thinking to ask the right questions?